This is basically not a study, it's more of case presentations. For lack of time, I have 3 cases, but I will at least like to present one. The first case is about a 28-year-old woman who came to the refractive OPD for blurring of vision, and she was taken up for a refractive lens exchange surgery. She had -19 in one eye and -20 in the other eye. She was operated with a multifocal lens in each eye, and the surgeon had recorded a BCVA of 6/6 and 6. She was treated with tear substitutes, checked for aberrations, glare, and contrast, because post-surgery, she said, my vision has become lesser. What do we do next? So the patient just wandered off into my OPD, and what we did next was we just lend a patient a ear to the patient's complaints. When a patient who's 6/6 is saying that she cannot say well, and especially after the surgery, her vision has deteriorated, we went back, listened to her complaints, and she said, first I couldn't see with the left eye, then even my right eye became blurry. I started bumping into objects, and my near reading became very poor. Although she was not on any regular medications for any systemic ailment, she had frequent headaches, and her menstrual cycles had been irregular since the past 8 to 10 months. So I re-examined with a fresh outlook, went across from as basic as an abnormal head posture to visual acuity, and I found out that after line number 6/18, she was reading less for all the letters that were coming on the first few letters on the left side. I also found out that she could read only 1 digit out of the double digits on an LED color vision map, Ishihara. A confrontation test was done, and it was revealed that she had bitemporal hemianopia. The pupil reaction was normal, and the slit lamp confirmed a quite pseudophakic eye with a well-centered posterior multifocal lens. This was how her fundus looked like. So she had a myopic fundus. Pallor was not that visible because of the tilted disc in the left eye, if you note. But then we went ahead and did a perimetry. The perimetry 30-2 was quite depressed, so we did a 10-2, and this is the picture that we came across. An urgent MRI brain was done with special attention to the sella and pituitary gland, and a well-circumscribed CSF signal intensity cystic lesion was found in the sellar and suprasellar region. It was not very invasive, so we were ruling out craniopharyngioma and sticking more to the Rathke's cyst. She was referred to a neurosurgeon who performed a cyst drainage through an endoscopic transsphenoidal surgery, and 3 weeks post-surgery, there was a marked improvement in the symptoms and the fields, as you can see. Quickly rushing to case 2, there were 2 cases of acute intermittent esotropia in a child. First case, I'm sorry, I don't have the pictures. Both of them presented very similarly with this kind of an esotropia around 15 degrees. In the first case, the BCVA was 6/6, stereopsis was present, and even though they said that the father was noticing a squint, when he came to me the first visit, he didn't have a squint. It was on the second visit that I discovered that he has a 15-degree esotropia. Whereas the other child, who was a girl, she had an alternate esotropia with left eye dominance, 40 prism diopter, esotropia for distance, and 30 prism diopter for near. Stereopsis was absent in this girl, whereas stereopsis was present for the first child. General physical examination was normal in both. So in the first scenario, accommodation and convergence was unaffected, but fatigue test was positive, ICE-PAC test was inconclusive, a pediatric neurologist opinion was sought, CT chest was normal, there was no thymoma, but the acetylcholine receptor antibody was weakly positive with an anti-MuSS negative. RNS and single fiber EMG was advised, which showed a decremental response more than 10%. He was diagnosed as juvenile myasthenia, started on pyridostigmine, and with the usual dose of 1 milligram per kg per day. He was better in 4 months and has been on a close follow-up since. This is the second scenario wherein the MRI revealed that she had actually an Arnold-Chiari type 1 malformation. Her earlier photographs did not show any squint at all, and it was true that this squint was lasting. It was not changing, having any diurnal variation as such. And the management was that she was referred to a neurosurgeon, and the neurosurgeon advised nil surgical intervention, though she underwent a strabismus surgery, 4.5 millimeter medial rectus resection and 6 millimeter lateral rectus resection, after which she has been orthotropic. So I will skip the last case for paucity of time and go back to the points of discussion. Go back to your basics, give due importance to the undilated examination. pay heed to subtle signs. Not all disc edemas are going to be needing steroids. Not all disc pallors are nutritional. Amblyopia is a diagnosis of exclusion. Intermittent symptoms without any signs, please be cautious before shunning them away and be thorough before a surgical intervention. See a patient as a whole, do not ignore the systemic history. Maintain medical records. And refer when in doubt, please. Thank you.
So what method was used to, sorry, it is not neuro, what method was used to test the stereopsis?
The stereopsis, basically what we did was a TNO was used.
Okay.
A TNO test was used. First, the basic titmus itself was absent for the girl, whereas the boy could read up to 40 seconds of arc.
Okay. I was interested because for distance the child was having suppression, but for near the child is having stereopsis. So, I mean, it could happen.
Yeah. It was, and like I said, for the first case, it was, because it was a myasthenia, he was on and off, so stereopsis was good.
So, actually, stereopsis may be good, but in that case, for distance suppression occurring is somewhat doubtful, because it is an intermittent thing.
It was intermittent, but
diplopia.
if you know, myasthenia is not going to be like a comitant squint. It is going to be more like an incomitant squint. So, when he was looking for distance, probably he was just focusing with one eye. Yes.
What I mean to say is, if we actually look as the child properly, they will be actually seeing an image on the other side. That is what I'm saying.
Thank you.
So that scenario 2, do you think that Arnold-Chiari malformation was related to the squint?
It was a sudden onset and we couldn't find any other thing, and she actually, after the surgery also, she was on continuous follow-up because she didn't have any systemic signs. The neurologist thought that it is better to follow up, and surprisingly, it's been, I think, almost 8.5 years now, and it has not come back. So we are just thinking maybe as she grew, maybe that was the reason.
Thank you.
Thank you.
Yeah, just 1 minute. What is the onset of symptom in the first case after the surgery? I mean, what is the gap? What it was before the symptom?
The first case, it was immediate, ma'am. It was very immediate.
After the surgery?
After the surgery. So, I mean, I don't know if scientifically we could find a reason, but what I feel is because she was -19 and -20 and wearing spectacles, she had always ignored her peripheral vision. And as soon as the specs went off and the lens came in, I think she became more conscious about the deficiency of the field and the contrast issues that she was having. Because it was immediately after surgery. She was a divorcee with a child who had taken 80,000 loan from her employee for getting this multifocals done, and she was very upset that post-surgery, whatever vision she had, even that had gone. So it was very immediate. Maybe it was just an accident.